right, everyone. Thank you so much for joining us. We are back with another Joint School interview, and our guest today is Dr. David Love, who joins us all the way from Melbourne, Australia, where he works as an orthopaedic surgeon. And our topic will be around the surgical approaches that are used when performing a hip replacement. And that's a topic that's been suggested by many of you, and there's been questions around this, and so I'm looking forward to diving into this. But of course, as ever, before we start this conversation, worthwhile saying that with this video, as with all the others, nothing we say here is medical advice and should certainly not replace the conversations that you are having with your own surgeon and other members of your team. And of course, also, don't forget to take a quick moment to track your progress in the Joint School app. And if you haven't downloaded the Joint School app as yet, it's a great complement to these videos. It's free, very quick and easy to sign up to, and you'll find details to that below this video. But I think that's about it for now. So without any further ado, here we are. Fantastic. Hi, David. Thanks so much for joining us.
Hello. Thank you for asking me on this show.
Yeah, this is like not good because I was very honored to be asked to join your podcast a couple of weeks ago, and I guess in some ways this is not too dissimilar from that. It's sort of a fairly informal conversation, but hopefully touching on some interesting points that people will find useful to hear, perhaps interesting, and maybe helpful depending on where they are in their situation and waiting surgery and recovery and so on.
Well, look, I think this kind of medium's really good, and we're only just getting started on using it, and I think the more the better, personally.
Yeah, absolutely. And of course, this will be on our YouTube channel, and could well be something that you can recommend to your patients, just as something to complement the conversations that you'll be having with them about these sorts of things.
Yep. Okay.
And so before we start and go through the questions that people have so kindly sent in to us, and please, if you're watching this now, as ever, feel free to send in any suggestions, any feedback, any comments, and if there's any at the end of this, if there's anything you'd like us to dig into a little bit more, or it sparks another question, fire away and we'll get to it.
Yep.
But before we start digging into the surgical approaches in hip replacement, what's the situation now in Australia where you are in terms of coronavirus and getting back to surgery? And
well, look, we've been quite lucky in Australia. Our numbers compared to some European countries and the United States have been very small. I think there's only about 7,000 confirmed cases or thereabouts across the country, and a very small number of deaths. So we've been very lucky. Some states in Australia are now completely have been new case free for some weeks. Victoria, where I'm from, and New South Wales, which are the most populous states, still have a trickle of new cases coming through. But as far as sort of the day-to-day life sensation is at the moment, we know we're not back to normal, but it's certainly, as far as the traffic we're experiencing and workload, things are seeming to get back to normal. There's more people down at the shops. People are still respecting social distancing, washing their hands with the sanitizer. Having temperature checks when you walk into hospital is still happening. But it's certainly, people are a lot more relaxed now than they were in early March.
Yeah. Okay. And you're back to operating.
So we're back to operating. I've personally had quite a busy week this week because of a trauma load at the public hospital I work at as well. Elective surgery, while it's returned, they're staging it. So we're meant to be at about sort of 50% capacity at the moment. So it is getting back to normal, and by the end of July, it's meant to be back to 100%. But we're certainly on the way to feeling what we normally experience.
Okay. So, that's good to hear. It's good to hear.
I think the bigger problem is a lot of people have actually, in some respects, quite enjoyed the shutdown in terms of It's been an enforced break, bit more time with family, time to reconnect, had a bit of time to slow down, catch up on things they haven't been able to do. And they're now sort of, while they're wanting to get back to work, they're also complaining about going back to work, if that makes sense. So it's I think people have appreciated the slowdown in some respects.
Yeah, no, indeed. But of course, for those here in the UK who may still be awaiting their hip replacement or knee replacement for some time, I think there's it's been affecting us in different ways, and here the situation is still that people are probably going to be waiting for quite some time for these elective operations, for these these joint replacements to really start getting going again.
That's been a problem here, and we know that there's going to be a build up in the waiting list for every elective procedure. So we know we're going to have to work hard over the next probably year or two to try and at least get the waiting list back to where it was. And obviously there's always an effort to try and continue to improve the waiting list and make it as short as possible. So the government's throwing money at it to try and offer initiatives to get people to do more cases, do more lists. But we just got to work through that.
Yeah, no, absolutely. And as part of that, now as ever, for people who are getting ready for a hip replacement or waiting for a hip replacement, it's all about knowing what to expect, being informed, and feeling that you as a patient, you as a person who are going to have this new hip, have an idea of what's in store, what's the what's the reasoning behind it, and crucially being invited in to take part in the decision making about your care and the plans for your surgery, and something that those conversations I think spark, as we see from the questions that are coming in, is around the different approaches that are used in hip replacement surgery.
So I agree with everything you've said there, and certainly patients that have had, I know there's new technology coming with internet-based, app-based systems, but certainly just from a personal perspective, I certainly know patients that have come in and have had 2 or 3 or 4 visits before they even make the decision to have the surgery, and have asked questions, and you've got to know them well. Empirically, I think those patients actually seem to do better than the patient that comes in, has a lot of pain, I want it tomorrow, and you sort of capitulate with that. But I think the patients that have spent a bit more time getting an understanding of what's going on, asked all the questions, I think actually do better post-operatively.
Mm-hmm. That's a really interesting observation, and hopefully we can contribute to some of that with this conversation. So just to really start with I guess the most basic point, what is a surgical approach? What does that entail and mean?
Well, look, essentially every operation, regardless of specialty, has 3 main parts. You have to open up the site that you're interested in, you have to do the operation, and then you have to close the site that you've just operated on. So that first part, what we're talking about today, is the way to get to where you want to go. It's like if you want to drive to a suburb, there's lots of ways to get to that suburb. And in some respects, it's very similar, particularly with the hip. And so there's probably 3 main ways of getting into a hip joint at the moment, or 3 approaches. And the approach is essentially through the skin, through the fat underneath the skin, through the fascia, and then there's usually some muscles, depending on which approach you take, that you have to navigate.
Mm-hmm.
Some approaches allow you to take muscles down off the bone and to expose the hip joint. Others go through muscle planes, and you don't have to detach very many muscles from the bone. like anything, each approach has different technical difficulties, has a series of advantages and disadvantages.
Mhm.
It can be very hard to say that one is necessarily better than the other. And at the end of the day, this comes down to a discussion with the surgeon as to what's the most appropriate approach for that patient.
Yeah.
And also, you know, just because a surgeon might be doing what's deemed to be an older approach that's been around for a long time doesn't necessarily mean you're going to get a worse outcome, because that surgeon will be very good at that approach. And what's more important is that you get someone who's experienced with that approach and comfortable doing it.
Yeah, absolutely. Absolutely. I think that's a really, really important, and perhaps the most important point from this conversation is that really the surgical approach matters less to a degree than many of the other factors. And you can have a very successful hip replacement with any of the different, common approaches. But that success will be defined by other factors. And it's about, finding a good surgeon who's comfortable with what they're doing, and that you as a patient also are comfortable with, what's on you and the process, and feeling informed and empowered to be active in your own care in each step. Just a note on what you were saying there. Just for those out there who might not be familiar with the term, the fascia is basically a layer of tissue between the fat and the muscle, just kind of as you're going through. As I remember, I'm not working clinically, and it's been a while since I was doing my anatomy stuff, but that's as
Well, I sometimes describe that to patients as it's kind of like underground skin, if that makes sense, as a sort of a crude way of describing it.
Yeah. And so, all right, so we've gone through a bit of an introduction to the concept of a surgical approach as the way of sort of effectively getting into the hip, or getting access to the hip to perform the hip replacement, and that there are different types of common approaches, and we'll go over the most common approaches shortly. But before that, what kind of things drives the decision-making process around how or why one might choose one approach over another for an individual patient?
So, look, there are sort of surgeon preferences here and patient factors that you'll take into account. As a general rule, my default would be what would be called a posterior approach, and that's an incision through the back of the hip joint, partly through the buttock muscles, and it's a very good approach in that it allows you to get a very good exposure of the cup or the acetabulum, and also the femoral head and the top of the thigh bone, which you need both of those bits of anatomy to be able to see in order to put in the artificial joint. The good thing about that approach is it's quite easy to do. It's extensile, meaning that if there is a problem during the operation, you can extend your incision quite easily. You can get to various things that you need to get. You get a very good appreciation of all the anatomy that you need to see. The downside of that approach is that there are some short muscles that have to be detached off the back of the femur, which will called the external rotators, which which we try and repair back down to the bone at the end of the operation, but it doesn't always take as well as we would like to. Mm-hmm. And as a general rule, when you take muscles down, we try and avoid it if we can, but we have to in order to do this particular approach. So because of that, the posterior approach probably has a higher, historically considered to have a higher rate of dislocation post-operatively. Now, there are various things that we do to try and prevent dislocation, and patients are educated about it. But that's one of the reasons surgeons have either tried other approaches or didn't move from the more traditional approach called the hard hinge approach because of their fear of dislocation. The advantage of the anterior approach is it preserves the muscles that are allow you to lift your leg out to the side. They're called the abductors, and that prevents you from having a significant limp after the operation. So in summary, the posterior approach allows good exposure. It's easy, but with the downside of maybe a slightly higher risk of dislocation post-operatively, but still preserves the major muscle groups that we're trying to preserve when you compare it to the more traditional approach of the hard-edge approach.
Okay.
Now, there are other approaches that are more modern, called via the anterior approach, and there's also the more traditional approach called the hard-hinge approach or anterolateral approach, both of which I still do, but the posterior approach is certainly, you could quite comfortably do it in every patient and still have very good outcomes for your patients.
Okay, interesting. And then, but there is that consideration around dislocation, which is something that, of course, many people watching this who are thinking about having a hip replacement or getting ready for it, or maybe have already had it, will be well aware of that possible risk. And of course, that's also why some patients will be given specific precautions to follow, certainly during the early stages of recovery. But indeed, many surgeons are also moving away from the hip precautions. So that's, again, for anyone watching this, that's very individualized, and you should always follow the plan given by your surgeon. But of course, as I understand it, the idea of moving away from precautions and sort of allowing patients to move more freely or feel less sort of restricted could be the case even with some of these approaches as well. So that's not necessarily linked to a particular approach as such.
So I think the reason surgeons have been able to move away from precautions in this setting is, one is, I think we're getting a better understanding of where the acetabular component or the cup component should sit in order to make the hip as stable as possible. I don't think we no longer have a sort of a one-size-fits-all approach to where the cup should be, and we know that some patients might need it in one position while other patients need it in another position in order to make it more stable. And there is technology coming into the market now that allows us to more individualize cup position. So that so for example, Axel, you might need the cup in one position very different to where I might need it, and therefore minimize the dislocation in both of us, for example. And they're the two things that I think are making us able to kind of ignore hip precautions. Okay. And I'm not saying ignore, I'm just saying certainly for the first 6 to 12 weeks, you should probably have some concern over hip precautions, but I don't think you need to be stringent about it.
Okay, that's interesting. And I guess on that kind of theme around recovery, is there, by and large, and this is speaking in very general terms, of course it'll vary more from person to person, but speaking very generally, is there any difference in your experience in recovery post-operative between the main different approaches?
So the other approach that I do in a minority of people is called the anterior approach, which is an incision down the front of more down the front of your thigh or your groin region, and there's a couple of advantages with that approach, and one of them is considered that it's a faster recovery, and it's considered a faster recovery because we're not taking any muscles down. We're going between muscles, between nerves, and you can get a good exposure of the cup and, to a lesser degree, the top end of the femur or thigh bone. You might then ask, well, why not? And in theory, that approach has a lower dislocation rate as well. And people might ask, well, why not do that approach in everyone when you've got these problems with the more traditional approach? The problem comes is, in regard to dislocation, it hasn't been proven that it's got a lower dislocation rate when people have studied it. And two is it does have a higher complication rate, particularly for on-table complications. And that has been shown both in my personal experience at the hospitals I work at and also in the literature.
Mm-hmm.
And so although there's some theoretical improvements in recovery time, it does come with a downside of doing a slightly higher risk. It'd be kind of like driving from one suburb to the next. You might get there quicker by driving it at 150 kilometres an hour, but you're going to run the risk of crashing. And you might not crash, but you might. Yeah. And that's kind of what the anterior approach is. It's maybe some better advantages, but there's higher risks.
Yeah.
And the faster recovery time is patients do seem to do a bit better in the first few weeks. 2 to 6 weeks afterwards, they seem a bit more better. Sorry for the bad English, with their pain, and they seem to get up and get moving a bit more quickly. I have had dramatic examples of patients, having physiotherapists come in on day one after the operation to try and find the patient, and the patient's already gone and walked down to the coffee shop to buy themselves the newspaper or a coffee or something. Yeah. So clearly they're doing quite well. However, the studies that have been done show that the difference between approaches by 6 and certainly 12 weeks has dissipated, and you're at the same point.
Right. Okay. That's interesting. So with the anterior approach, by and large, maybe a bit of a quicker recovery, but higher risk potentially, and then in the long term, perhaps not so much of a difference.
Yeah, and correct. And the other thing I like about the anterior approach is I can do an X-ray quite easily during the operation and check what the component position looks like under direct vision with the X-ray, and that can be quite helpful. Mm-hmm. It's harder to do those X-rays with the more traditional approaches. Mm-hmm. I know some surgeons who do it, but it certainly adds a lot of sort of mucking around trying to get the X-ray in the right position and getting the patient in the right position, because we do place the patients in different positions for each approach.
Yeah. Okay, yeah, that's interesting too. And I guess perhaps it's worth flagging as well for anyone out there who's watching this who is booked in for an anterior hip replacement, that while the risks are higher, most of the complications are treatable.
Yes.
And
look, yeah. I would also add, look, I've had some patients come to me who want, they said, I want an anterior approach to the hip because they've read about it or a friend's had it or whatever. And after assessing them and particularly what their anatomy looks like in terms of their hip anatomy and proportions and the shape of their hip, and everyone is different, I say, look, I don't think you're going to be a good candidate for an anterior hip replacement because of these reasons. And look, initially they're disappointed because they had in their head that was the best approach and that's what they wanted. But I've told them my reasoning, and I've done the more traditional approach. And those patients have been still very happy. They've recovered just as quickly. Maybe they're a week or two slower than if they hadn't had the anterior approach, but really a week or two in the scheme of things, it's not really a big deal, particularly if you're retired. I mean, there really shouldn't be a rush to get back to anything. And they're happy. They've been some of my happier patients. So, I've never wanted to purport myself as an anterior hip surgeon. I just wanted it as another option when offering patients surgery. And I don't think patients should be disappointed on what approach is chosen. I think it should be tailored to their needs and have a discussion with the patient about it.
I think that's absolutely right. I think that's perhaps one of the key takeaways from this conversation. I think is that it is an individual decision, and it's based on that individual case and the conversations between each patient and their surgeon.
Yep.
Yeah. But on that, and from patients who are reading about the different approaches and so on, I know also that we get fair amount of questions around minimally invasive surgery And
Yes.
how does that relate to the different approaches?
Well, it's funny, just like, you know, the fashion world, surgeons have fashions, and like 10 or 15 years ago, every conference you went to, there was a talk about a minimally invasive approach, smaller and smaller incisions, basically just large enough to be able to fit the cup through the hole to get it into where you need it to go. And most cups are sort of in the sort of 55 millimeter range, give or take 5 millimeters. And, but there is a bit of showmanship about, I'm doing my incisions through an 8 centimeter. Well, that's great. I'm doing it through a 7 centimeter incision. The reality is, it's one of these things where I don't think there's a huge difference whether you've had a 10 centimeter incision or a 15 centimeter incision or even a 20 centimeter incision. It's obviously the shorter the incision, the better, but you want the operation done through an incision where the surgeon can do it safely.
Yeah.
And sometimes you just need a bigger incision to be able to safely see what needs to be seen and to put the components in where they need to go. I mean, I personally would rather the surgeon add a bit of length to my incision and put the cup and the stem in where it needs to go so that I get a functioning hip replacement rather than worrying about doing it through a tiny incision.
Yeah.
And obviously we try and keep the incision to the shortest length we can, but we also need to see what we're seeing.
Yeah, no, absolutely. But that brings me. I mean, that's very wise. That safety first, of course, always. But nonetheless, it does bring me to the next question, which has been sent in, and I promised I would ask it.
Yes.
To do with scarring afterwards. And is there, in your experience, is there any variation in terms of scarring from one approach to another approach? Are certain approaches more likely to need a bigger incision or scar differently?
Look, the anterior approach probably is a slightly shorter incision. But I actually think the posterior approach incisions actually heal better. I think it's because they're over a bit of the body that's a bit more meaty. It's over your bum, basically. So it's a bit more meaty and they heal very nicely. The anterior approach scars do heal quite nicely, but sometimes in that skin crease between your abdomen and the top of your thigh, the incision can get a bit scarred or tethered, or in the healing phase, it can get a bit mucky in that area. It's just because it's a skin fold area and it can get a bit moist and the skin just doesn't like that. And, so probably the posterior incisions actually look a bit better down the track, but that's a minor consideration in my opinion.
Okay, interesting. And before we move on to sort of any differences in approach and so on, further down the line, one final question that was sent in was from someone who is due to have a hip replacement on the other side. So they've already had one, and they're wondering, does that mean that they will have to have it using the same approach, or could there be a situation where you might have a left hip replacement through a posterior approach and say a right hip replacement with an anterior approach, for example?
That's I really like that question, partly because I don't know the right answer. And as a general rule, most surgeons will try and mirror, the right and left side and copy what was done previously. Sometimes with these patients, they might have had a right hip replacement done 15 years ago by someone doing one approach, and you've decided to use a different approach. So you will have a different incision and a different position on the around the hip there. I don't think the patient needs to get too fussed about having a different incision on each side. Again, it comes down to what's more important is that the cup and the stem are put in the right position and that the hip functions well. I've certainly done patients where I've done one approach on one side and another approach on the other side. And sometimes the reason is probably not what the patient would think. Sometimes it comes down to equipment issues. So, for example, with an anterior approach, you need a special leg holding device and a few extra bits and bobs that you don't need when you do a posterior approach. And if sometimes you find out on the day of the operation you're going to do an anterior hip, the leg holding device is broken, or it's not available, or you can't do it. So you've then got the choice for the patient, well, we can either do a posterior approach or we can cancel your operation and you can come back on a different day. And I always give the patient in those rare circumstances a choice, and they always say, just get the operation done. And so they're happy to accept a different approach and incision.
Yeah. Interesting. And I guess again, that highlights that, you know, in the right hands, there's not much to it in terms of the difference between the approach.
No.
Very interesting. Okay, so moving on chronologically, this is pretty much the last sort of question, really, and we've had a fair few questions. We've got quite an engaged audience of people who are a bit sort of younger than what has been the norm in terms of having a hip replacement, and many people in that group are active, and they might be professional dancers or doing quite active work in other ways, or having hobbies and so on. And so there's a few questions around in terms of the activities that they will be able to do safely with a new hip. Is there any variation in terms of the approach?
I don't think so. Once you've recovered, particularly by the 3-month mark, I don't give advice saying because you've had a posterior approach, you can do sports X, Y, and Z, and because you've had an anterior approach, you can do sports and activities A, B, C. I don't think the approach is relevant.
Yeah, they'll be more individual again
to those activities. I mean, there are some activities based on a hip replacement alone that you probably shouldn't do. If you've got a hip replacement that's been done well and you recover well without a complication, and you're 50 and you want to go back to skiing and you feel up to it, people do that. And for example, so, and I think that's independent of the approach.
Yeah. Okay. That's interesting to know. And in terms of, I guess, a related question really is there any difference, generally speaking, very generally speaking, in terms of the longevity of a new hip and how long one might expect a hip to last, depending on the different approaches?
I don't think we've got an answer on that at the moment. I know the Australian Joint Registry several years ago started collecting data on which approach was done for each procedure. That data is probably not far enough along to give an answer to that question. My gut feeling is it probably won't make any difference. But look, there has been examples in the registry where the survival curves of 2 or 3 variables are compared, and at 5 or 6 years they're all the same, and then at 5 or 6 years they start diverging. So I think this is going to be a watch this space, and I think the Australian Registry will be in a very good position to answer that question, but probably not for about 10 years.
Interesting.
Yep.
Well, so we've talked a bit about what a surgical approach is and the most commonly encountered variations on that in hip replacement surgery and a few points around it. And I think really what we're circling around is that it remains very much a case-by-case decision, and really there are many other variables that are perhaps more important. But is there anything else that you would add to this conversation, or anything that you feel that you would have touched on with your patients that we haven't here?
No, look, I just tell patients, look, some patients come in with their heart set on a particular approach, and I just basically discuss all the things we've discussed in this session, and look, if they're appropriate, it's usually the anterior approach they want because it's sort of newer, it's a bit cooler, and there's a little bit of marketing behind it and people building up their practices and so forth. But look, if they're appropriate for the anterior, then fine, do it. Particularly if your surgeon is a surgeon who's comfortable doing that approach. If, however, you go to a surgeon who doesn't do that approach, or doesn't believe in that approach, then don't get disappointed that you're getting a different approach to what has been advised. I mean, if that surgeon's got a good reputation and has done several thousand joint replacements over his or her career, then there is no reason that you're not going to get a good outcome because you're getting a different approach to what was in your mind.
Yeah, absolutely. That's a really good point to end the conversation on. Really, I think that really highlights the key thing about these approaches. And hopefully for those of you out there who sent in the questions, thank you so much. Please do let us know what you thought about this session. If there's anything you feel we should dig into more, or that there's there's so much to cover around hip replacement. So I'm trying to break the sessions down a little bit more than we have. So if we've missed anything, do let me know, and we'll get to it in an upcoming session. And again, thank you, David, so much for joining us. It's been a real pleasure.
Thank you for asking me on. I'm very much enjoyed it.
Yeah, fantastic. All right, bye-bye now, and bye-bye to everyone out there. As ever, stay well, be safe, and keep up the good work. We'll see you next time. Thank you.